told Bob and Marianne is that I love black and white, but the wearing of the zebra print, I'm just not bold enough to wear zebra print clothes. So she bought me these shoes. So I think I'm bold enough to wear them on my feet, because then you can be like, oh my God, those are totally cool. Okay. So I am also now talking to you about the surgery part. So I am a surgeon by training, and then I think over the course of probably the first 10 years of my career, because I am now 21 years into my career, I was predominantly a surgical oncologist, and then I became a lot more interested in cancer programmatic development, and especially cancer programmatic development for sort of disenfranchised or marginalized patient groups. And rare cancer people fall into that group. But I'm still a surgeon by training, and so a lot of what we do in the New Orleans program is we're probably considered the most assertive. I wouldn't necessarily say the most aggressive, but the most assertive when it comes to surgical cytoreduction. So that's when I say I think it should come from a surgeon. A lot of times what we do surgically is in the eye of whoever is interpreting the films. And although I think historically maybe we didn't have quite as many treatment options, and so we relied on surgery a lot more than maybe we need to now, but that at the end of the day, surgery is still a really critical component of what we do in neuroendocrine. So the objectives of this talk is to better understand what variables weigh most heavily into surgical decisions, the data that supports surgery as a treatment option, how it is one of many treatment options that are not mutually exclusive, and morbidity. Okay, morbidity is just the medical term for what are the types of complications that people would have that would actually influence either their recovery of surgery or in some cases may influence the rest of their life. And so I think that when you're looking at a lot of the different therapies that we offer, surgery is probably the one with the highest morbidity. I think liver-directed therapies is probably the one with the second highest morbidity, but they also come with the greatest objective response rate. So there are three main questions when you're talking about surgery. Okay? Can all measurable disease be removed? That's when we're doing things with curative intent. Okay? And that includes the primary site and metastatic disease. So you can still do something with curative intent, even if someone has stage 4 neuroendocrine, if you can remove all measurable disease with surgery. So a lot of times as surgeons, we're looking at films saying, can I remove all measurable disease? And then I'm going to tell you that there's still a survival advantage even if we don't, but that can all measurable disease be removed, because then we'd have to have a kind of a good reason for not offering surgery. What risks are associated with the operation? That has a lot to do with the primary site, the location, the extent of the tumor burden in the organ site, and the potential for complications or morbidity. And are there the little suitcase thing, are there other medical conditions or surgical comorbidities that would impact an individual's ability to recover from the operation that we need? The last thing we want to do in neuroendocrine in patients that live a long time is trade off one problem for a different problem that you would have to struggle with. And so, for example, I'll go into that with like mid-gut primaries. You got to have an intestine in order to nourish yourself, so you can't do an operation where you lose too much, intestine, and it's a trade-off of one problem for nutritional related problems. Kira, I've already been over that. I really like that slide. So surgery done with curative intent. So this is just putting you guys into categories. If you have local disease with no evidence of distant metastatic disease. So what are examples of that? A small bowel primary, where a small bowel resection with a mesenteric lymph node dissection is all you need. Okay, that's no different than colon cancer, colon plus mesentery. That's no different than breast cancer plus sentinel lymph nodes. So gastric cancer, stomach. So local disease, no evidence of distant metastatic disease, that is done with curative intent. A pancreas primary, you do a pancreas resection with peripancreatic lymph node dissection, that is done with curative intent. Lung primary, where you have a resection of a lobe or a wedge resection plus or minus lymph node dissection, depending on the preoperative imaging. But it also, you're allowed to do the limited metastatic disease where you can completely remove all of it. And in neuroendocrine, you will have a subset of patients that will not actually have additional sites of metastatic disease. I will tell you that that is actually kind of counterintuitive, because oftentimes it will be a person with maybe a pancreas primary and like a single but relatively large tumor in the liver, as opposed to someone that has actually smaller volume disease. So it's kind of a weird thing to think about, because we are more likely to actually do that operation than to do an operation where you would be taking out innumerable ones in the liver, although we do that too, but innumerable ones in the liver, we wouldn't be doing it with curative intent. So surgery done with palliative intent. You're removing enough tumor burden to decrease symptoms of neuroendocrine syndrome. So the most common is going to be metastatic midgut with carcinoid syndrome. Removing tumors where the location is associated with pain. Mesenteric tumors that are causing poor blood flow, so a lot of the postprandial after you eat and you get that crampy abdominal pain. So depending on where the lymph node basins are, we can actually go in and debulk that and release some of those blood vessels and get better blood flow to the small intestine without actually necessarily taking out the entirety of that tumor burden. But the point of that is actually to diminish pain. Yes, I think if we can take out a critical mass of the tumor, that's associated with a survival benefit, but ultimately it is trying to reduce those symptoms that you have after eating. If we were to go into some of the things that I feel where histotripsy, that ultrasound-based thing that Andrew Marcello mentioned, is that my reasons for getting a histotripsy machine in the southern part of the United States was for people with base of the mesentery tumors. I just can't use it there yet, but I am hopeful that we will be able to use it to try to debulk tumors without having to do surgery, which is considered just a little bit more complicated. Large pancreatic tumors, those can cause a lot of symptoms, but they can also cause growth. They can cause portal hypertension. You get varices, you get GI bleeds. There's a lot of problems when pancreatic tumors become large, or large liver tumors that can be pushing on something, causing obstruction of bile ducts and things like that. Tumor causing obstruction would be a bowel obstruction, a bile duct obstruction, or a bronchial obstruction. That's something in the lung. And tumors causing bleeding. It's usually going to be intestinal bleeding. And then surgery for prolongation of life in neuroendocrine is, we have all sort of in innumerable papers, but pretty much at our national meetings where we're talking amongst the neuroendocrine people, is we say you got to be able to do a critical mass. And you say, well, what's your critical mass? And you say, what's your critical mass? Well, we've all decided that 70%. That doesn't mean 69 doesn't work and 71 does. It's just that we try to make some critical mass, and we have written papers saying that if you can meet a threshold of 70% of the entirety of the disease burden that is associated with a survival benefit over taking medical management or other types of multimodality treatment. Okay, so you have to know how much tumor we have and where it is and whether or not we will be able to meet that 70%. So a lot of times at tumor board, all of us are looking at the images and the surgeons are all looking and saying, can I meet the 70% mark? And Andrew Marcello is sitting up there saying, can I meet the 70% mark, because he's doing it in a different way, but ultimately he's also trying to shoot at a critical mass. I mean, he showed an awesome thing. So what he may or may not have mentioned is that I told you it was an 80% objective response rate with liver-directed therapies. That drops to around 55% durability, meaning how long that would last. He's saying, I don't know how long it'll last. But if you are one of the people with in that 55% at 6 months, it can last you for years. So the durability is questioned because it drops from 80 to 55. But if you're in the 55, then it can last for years of time with no other additional treatment. So it's a very good cytoreducer, even though I'm talking about surgery. But surgery is the same thing. Morbidity is just the complications that are associated with whatever surgery we are describing. So this is just going over some of the nuances of how we make decisions. So the small bowel and the colon anatomy is pretty much that you have, it's just hard for me to do. So you have this right here is you have the big old blood vessel. There's a big artery that starts from your aorta, and it goes and it branches out all here, and all of these little things are going to parts of this small bowel, which is the big sausage. Okay. And then your colon is like this big horseshoe. Similarly, it's going to have its own blood supply, some of which it shares with the same blood vessel of the small intestine, which is why when you've got a tumor that's way close to here in the small bowel to colon junction, which is a lot of the ilioprimaries, you end up losing not only your ileum, but you lose this valve, and you use part of your colon. And for whatever reason, when we do that operation for colon cancer, meaning you have a colon cancer on this side and we do a right hemicolectomy, or you have a neuroendocrine on this side and we do a right hemicolectomy, neuroendocrine patients don't tolerate that right hemicolectomy as much. They have more diarrhea type symptoms after that case. And it's because you have a valve here, and for whatever reason, even if it's the same exact amount of stuff that you lose, neuroendocrine patients don't tolerate it. It's usually diarrhea that they struggle with. So then when we're talking about mesenteric involvement, we're talking about where it is relative to a lot of these blood vessels. So this is just an example. I've got a big old thing sitting right in the mesentery. Oftentimes, if it's in the sausage part, which can be a very small tumor, and you can have a big rock sitting in the mesentery, or you can have a small tumor here causing an obstruction, and you can have like a tiny thing in the mesentery. It's just that when we're looking at small bowel primaries, we're looking both at the sausage and at the mesentery. And so the closer that is, getting towards the center of this, then the more tricky it is to remove something without jeopardizing the remaining colon that's there, because it all obviously has the same branches of the blood supply. So when it comes to surgeons looking at images on a small bowel, a lot of general surgeons in the community, say for example, you go in, you're obstructed, it's an emergency, they have to go in and do something because they have to save your life. So they're going to go in and they're going to deal with the thing that happened. And they're going to see that thing in the mesentery and they are not going to want it. They're going to be like, no. I can't deal with that component of it. I just have to deal with this component of it. And then they'll send them on to someone that can manage it. Or they're going to go in there and easily be able to manage it. So it's not as if general surgeons can't do these. These are general surgery cases, but it's the mesenteric involvement that is tricky. So this is just the difference when you're thinking about where it is in the mesentery. So if you have something that's sitting way over here, right over here, and it's really close to the sausage, I'm going to go over. That's like so easy. It's a little like a chop, chop, and you put it back together, and you aren't even going to notice it, okay? Then you've got this one right here with the big tiger. We call that tiger country. In all seriousness, we call that tiger country. You're like, oh, no, you don't want to go there. That's tiger country. And that is because the closer it gets to the middle is that these tend to be pushing tumors, not so much invading tumors, but that as pushing tumors, they will literally grow around and through. And so you're kind of trying to chisel it out of tiger country. And there's just a lot of real estate down there that matters because that is the main blood supply to the entirety of your colon, the entirety of your small bowel and probably a third of your colon. So we call that tiger country, which is why most of those cases, you're either going to be deemed unresectable because no one's going to be having the guts to do it, but that is, I suppose, where within the neuroendocrine community, we are currently the center that does that, and probably almost 100 times a year we'll get referrals for something that we call, oh yeah, it's another tiger country. So the types of the surgery of the small bowel. So this one, I believe, is just a little chop. So you're literally doing this thing. Sometimes in general, so we're talking about, when we talk about laparoscopic versus open procedures, I think prior to our having the gallium-68 and the PET and the copper PET imaging, I think that we were much less confident that we were going to be able to do things laparoscopically. Laparoscopically, beautiful operation, minimally invasive, whether it's robot or laparoscopy. You can go in, and it's just the recovery for you is just much shorter. But that you can have small deposits and multifocality within the small intestine. And so all of us like to be able to like almost inchworm the small bowel and make sure that we're taking out the entirety of the disease. And we just didn't feel like we could do that laparoscopically. And so you will have like papers upon papers out of UCSF and other like large surgical programs that talk about, oh, can we do it through a little belly button incision and kind of like slowly like bring it all out or whatever. And many of us will stick to a kind of a minimally invasive, a smaller incision, but we still want to make sure that we can at least feel the tactile sensation. I personally think that in the next 5 years, with the introduction, now that we're comfortable with the PET scanning, is that we have done many cases where we've shifted some of these like if it's just one of these choppy cases, is that we've shifted those to laparoscopy, and we have not had significant issues with recurrence in the nodal basin. But if you have the PET scan showing you have limited disease, then you aren't as suspicious that you're going to be missing something on this. Now, it's going to take a while because we only shifted to that probably around 2 years ago, and mid-gut neuroendocrine patients with limited disease live a long time. So it's a little hard for us to know whether or not we're going to be 100% comfortable with that, but that a lot of the reasons we've done it is it going to be in people that have other medical conditions that an open operation would have been trickier. So we've just decided to sort of cut bait and do a less invasive. So this is a very low risk operation. It's maybe 2 or 3 days in the hospital, relatively easy to recover from. Now, if you were to talk about, because now I look at all the people that have more complicated small bowel operations, when you're going in for the second time or the third time on people that have previously been operated on midgut neuroendocrine tumors because of recurrence in their small bowel or their mesentery or whatever, no, those could be incredibly tricky, but that's mostly because it's a reoperative bed. So these are just what it kind of looks like on the CT scan. So this is what it looks like if you were to go over the CT scans with your physicians. So this is what it looks like, that mesenteric involvement. Okay, I don't even think that this really is. It looks like it's a little bit farther in the midline, to be honest with you, on that CT scan. But the long and the short of it is that's what the specimen looks like. So because of the location of that tumor, yes, this was ultimately the amount of small bowel that was lost. Now, granted, you have a lot of small bowel, but that the least amount of small bowel, our goal is to take out the least amount of small bowel that is necessary to get that negative margin. So the base of the mesentery, this is what it looks like on that same type of scale. So you've got a big thing, but you see how you can't even see it. You just see it, and then you see this little spider web of stuff. That's all the way that your body is trying to find blood supply that will go around this obstruction. And so these can be incredibly challenging because you need to ultimately be able to somehow chisel the main component of that without jeopardizing a significant amount of that blood supply. And so this is what a bowel looks like. I'm trying to think of where this. So you see how you've got this thickness right here. It almost looks like a target sign. This is the oral contrast that someone doing. And then you see that this is all really thickened. And then you look over here though, and over here, this is what a normal bowel looks like. So when this is thickened, that's because over time, the bowel, when you eat and you stimulate it saying, I need more blood flow, and it can't get enough blood flow, then it'll be unhappy. You'll have an inflammatory component on it, and it slowly scars, and ultimately that scarring can cause obstruction. So the complications of midgut neuroendocrine tumors are going to be ischemic bowel. That's when you don't get enough blood flow. And the issues with that and why we follow those patients if they are unresected very, very closely is because when they get into trouble, they can get into trouble from one moment to the next. And if that is going to be while they're on vacation in Alaska, that's a really significant problem. And so we would usually prefer to have a game plan to be trying to operate with palliative intent, likely also to prolong life in order to keep something from happening. So I will usually recommend an operation when I start to see changes on a CT scan that are suggestive of ischemic bowel, and that's that thickness. Short gut syndrome, we call that acquired short gut. Now that is different than functional short gut because you don't even have to operate on a person with a really bad carcinoid syndrome with a midgut neuroendocrine tumor, and they can still have short gut syndromes, meaning that it's getting from the top to the bottom too quickly. So you have malabsorption from that. So it gets from the top to the bottom too quickly. Or your intestine is just losing its ability to break it down and absorb it in the time that it has. And so functional short gut can also leave you nutritionally depleted, and you will then struggle with malnutrition, for which then we would likely have to consider some form of treatment. And then I put acquired short gut because surgery is responsible for the acquired. That means by doing surgery, you may or may not have had it before, but now you have the same problem. So now you have to say, is it because it's getting from the top to the bottom too quickly? Is it because your intestine doesn't have enough time to break it down and absorb it? Is it because the obstruction caused the other small bowel to be so unhappy that it's going to take like months of rehab in order to get the proximal small bowel back in the game? Or is it because you just lost a significant amount of small bowel, whereby your ability to maybe, for example, absorb B vitamins like B12? So then we have to keep that in line because we're going to have to know that if you lose a significant amount of your ileum, you will lose the ability to my word finding different is absorb bile salts, meaning that you would then struggle with bile salt diarrhea, for which then we would have to treat you with a bile salt binder like cholestyramine. If you lose a lot of your proximal small bowel, well, who knows? You got iron. All of your iron, folate, and everything is absorbed by your proximal small bowel. That's what it makes proximal, meaning they're still in the midgut, but they're in the jejunum, not the ileum. And the jejunum is your cholesterol and your folate and your iron. So those people will struggle with iron deficiency. And so I think where we miss the boat is that we do an operation without truly understanding what the consequences of the operation are. And then people are struggling with things that are completely treatable with a bile salt binder or with B12 supplements or with iron supplements. And yet we don't recognize it, and so people don't get treated for it. That is more likely going to happen in something that does not have a multidisciplinary team, where they are aware of then the consequences of the operation. Because if it's done, especially in the community by a general surgeon, they just don't deal with all of the acquired problems. So malnutrition, malabsorption, refractory diarrhea, and then carcinoid syndrome is the rapid transit, and that's usually serotonin, and then that is the Zermello. People are trying to diminish the intestinal manifestations of carcinoid syndrome. So the pancreas anatomy, I told the pancreas is like a fish. You've got a head, a neck, a body, and a tail. And the location of a tumor within the pancreas really matters because the complication rate associated with any operation is going to be related to that location. So, and then obviously this is just a Google image showing you, then the lymph nodes are all around here. Those are the green things. And then this is showing you all of the blood supply. So the problem with the head of the pancreas is it shares the blood supply with the duodenum here. And so trying to take the head out of the thing without taking the duodenum would be like trying to chisel an apartment out of the middle of the apartment building, and then you're trying to like put all the apartments back on. So operating on the head of the pancreas is complicated. Well, it's not even that complicated compared to operating on the neck of the pancreas, because the neck of the pancreas is sitting right here, and it is over all of the critical structures that are all those blood vessels going to your intestine. And you don't have an intestinal problem under these circumstances. You have a pancreas problem, and so maintaining those blood vessels is imperative. So neuroendocrine tumors within the neck of the pancreas are probably the most complicated that we have to deal with, because once again, they could be very slow-growing tumors, but they're growing in a very awkward spot. Leaving them in that awkward spot can be very difficult. So doing nothing has consequences. Doing something has consequences. And so if I were to ask it, I would beg for it to be in the head before I'd beg for it to be in the neck. And then the body and the tail are a little bit easier. The body is problematic because a lot of your exocrine, all the pancreatic enzymes that help you digest your food, and then some of your insulin production is within the body. And so losing the body, then you lose the tail because it's connected to the body. And then the tail is honestly like going into the fishmonger and saying, I just want the tail. And you just go, okay, here it is. So the tail, super easy, usually done laparoscopically. So the types of pancreatic surgery that are really just this. So you have a classic Whipple. I'll show you pictures of that. A pylorus-sparing Whipple, a distal pancreatectomy, a central pancreatectomy, and an enucleation. So a classic Whipple. This is really only almost going to be in the preference of a surgeon. So if someone's saying, oh, we do pylorus sparing and that's so much better, I would not say you have any data to suggest that pylorus sparing that Whipples are better than classic Whipples. The difference between the two is one spares the valve between your stomach and your duodenum. And so some of the complications or the morbidity of that is that in devascularizing, in taking out a lot of the things that connect it to it, sometimes you can have very significant delayed gastric emptying. People complain of bloating, they have intermittent vomiting, a lot of gastroesophageal reflux disease. And so the papers would say that after 6 weeks, that all goes away. Well, in real life, it doesn't go away. So people that have delayed gastric emptying after a pylorus-sparing Whipple can have a lot of symptoms. So the classic Whipple is one where I have a picture of the pylorus-sparing too. So the classic Whipple, we are taking the first portion of the duodenum, we are taking the head of the pancreas with the cancer in it. We are taking the acid-producing part of the stomach. That's called the antrum. And then you're taking all that out. So now I've got and you're taking out the gallbladder. So now I've got a stomach pipe, and I've got a bile duct pipe coming from the liver, and I've got a pancreas at the neck, whatever. And now I've got to reattach those onto the intestinal track, kind of like the apartment analogy. And this is what it looks like afterwards. So you have the pancreas onto the thing, and then you've got the bile duct coming in onto the thing, and then the last thing that you have onto it is the stomach. And the reason you need to do the stomach last instead of the stomach first, which is under normal anatomy, is you can't have the stomach feeding into that limb, or you will get reflux up into the stomach, and the stomach doesn't like that. So a classic Whipple is probably the more common that is used for really all pancreatic adenocarcinomas, but for a lot of pancreatic neuroendocrine tumors within the head. And I think that the problems that we've had with the classic Whipple were that people would dump food prematurely into their small intestine. So that the stomach is usually, you eat, it sits in your stomach, churn, churn, churn like a cow, and then it delivers it to your small intestine in smaller, safer quantities. But that by taking out the toll bridge or the valve that keeps the stomach it keeps the food in the stomach to churn, 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 it gets prematurely into your intestine. Your intestine's like, this isn't even remotely digested. What am I supposed to do? It gives people a lot of indigestion. That's called dumping syndrome. But that with a lot of our stapling techniques now, I think that we have been able to really re-anastomose the stomach to the intestine just in a much smarter way than we used to. So you just don't have such a wide gap. So it's not like it's all just dumping from your mouth all the way into your stomach. It does actually stay within the reservoir of the stomach. So we really haven't had as many issues with dumping after classic Whipple, and I think we've just gotten better at it. So a lot of us have just preferred classic Whipples because the delayed gastric emptying, NG tubes and things like that is really miserable for patients. Pylorus sparing is supposed to be more physiologic because you're maintaining then that churning component of the stomach and these smaller, safer quantities into the intestine. But the delayed gastric emptying is really a significant problem. But at the end of the day, the reconstruction looks very much the same. Distal pancreas splenectomy, these are often done robotically now, and that's because neuroendocrine tumors tend to be pushing instead of invading in tumors. This is an adenocarcinomas, meaning the other type of pancreatic cancers, tends to be very much invading types of tumors, and yet even with pancreatadeno, we have shifted to a lot of less invasive techniques. So when people have a tumor within the body or tail of the pancreas, I would usually, in my second opinion, say, is there some reason they did not mention doing this minimally invasively? Because I think many centers have shifted in that direction. There could be a very good reason they aren't doing it minimally invasively. We do open procedures all the time, but that for the most part, I think that probably 80% of pancreatic neuroendocrine tumors within the body and tail of the pancreas are done minimally invasive. If they are done minimally invasively, you lose the spleen because it is way too difficult to try to spare all of the branches between the posterior aspect of the pancreas and the splenic vessels, and so it just raises the risk of bleeding minimally invasive. If someone has a relatively small tumor in the body or tail of the pancreas and we do it open, I think probably we have maybe a 40% chance of saving the spleen. It's not really that big a deal in adults because most of our immune system is matured and is mostly within the systemic circulation, but it still is. I would prefer to save a spleen if I think someone has a small, well-differentiated tumor I'm doing with curative intent, and I never want them to have to see me again. And so I would likely save the spleen, but for the most part, the robot sacrifices the spleen. A central pancreatectomy, I really think that if someone is talking about doing a central pancreatectomy, I would be like, say, you need to get a second opinion. It's a really, really tough case. It's a tough case, and it's supposed to spare the endocrine and the exocrine function of the pancreas because you save the tail, and you save the head, so you don't have to take out the duodenum. It has the highest complication rate of almost every operation that we do. So I usually just say, if they say, oh, sure, I could do a central pancreatectomy, you're gonna be like, okay, before you do that, I'm gonna have to go get a second opinion because I've heard that that's, I went to a conference and I heard that that's a really tough case. And then someone's gonna say, oh, I do them all the time. And it's like, no, you don't, because we really do not do central pancreatectomies very often at all. But that is where you are literally cutting the neck out because you have a well-differentiated neuroendocrine tumor. The pancreas on this side is soft like mozzarella cheese, and the pancreas on this side is soft like mozzarella cheese. And even though this looks like a really, really tiny little like thing right here, that soft mozzarella cheese does not take stitches very well at all. It could leak from here, it could leak from here, and it's really, really difficult. So I would say most of the major complications we have after, so I would just end up saying you either have to decide you're going to do an extended Whipple and save the body and the tail, or you're going to do an extended distal pancreatectomy, splenectomy, and save the head. And then, once again, that's going to be patient-specific. If someone is already diabetic, then I would choose to do the tail. I would just, and then save the head because the Whipple's more complicated. But if someone is not diabetic and is otherwise healthy, I just do an extended Whipple because they're likely to not have any significant problems. So tumor enucleation is something that we also don't do very often, but is a valid treatment alternative. It is most often used for insulinomas. Those are they can be small tumors, and they are often non-invasive tumors, even though obviously we have cases of metastatic insulinoma that can be very challenging to treat, but they are usually non-invasive tumors that are just within the pancreas, and the patient is actually not suffering from the tumor, it is suffering from the insulin production from the tumor, and so usually we can core them out. If you can enucleate them because they are not that close to the main pancreatic duct, which is what's bringing all of those very irritating pancreatic enzymes into the intestine, then usually the issues with it, if it's too close to the duct, then you can get a pancreatic leak. But I'll tell you right now, an enucleation is not associated with nearly the morbidity associated with a central pancreatectomy. So you need to have an insulinoma. It needs to be low grade. So we've done this with gastrinomas too. So gastro-producing tumors, VIPomas that are single areas. We've done it with VIPomas. They are most often done for insulinomas, and they are done for functional insulinomas, and that is just to drive the insulin levels down. They have to be located away from the duct. They're relatively small, and we're doing it if it's in the neck of the gland. So what information is important? Is it functional versus non-functional? Because you can't leave someone, you got to have a treatment that is going to deal with the functional aspect of a pancreatic neuroendocrine, like a VIPoma or a gastrinoma or a glucagonoma, because the functional component of it can be devastating. The size of the tumor totally matters. Is it less than 1 to 2 centimeters, or is it greater than 2 centimeters? The relationship or involvement to adjacent structures, the grade, the differentiate status, the intensity on ESA, all of those things weigh in to how we make decisions about pancreatic neuroendocrine tumors that we would probably blow off and just be like, whatever, it's the intestine. No, the pancreas really does not like being operated on, and so you really do have to have a good reason, and you've got to really be quite confident that you're going to meet your treatment goal. So metastatic pancreatic neuroendocrine tumors are considerably more complicated. We have guidelines but lack standards. This is where I would also consider a second opinion, because there are a lot of people that may have differing approaches to pancreatic neuroendocrine tumors. Okay, they are more likely than midgut primaries to require multimodality treatment strategies. Okay, so therefore you have morbidity associated with liver-directed therapies. You have morbidity associated with your surgeries. You have morbidity associated with chemotherapy. So I will usually have a much longer conversation with someone with pancreatic neuroendocrine about like why we would choose one thing first, like we would see a path forward so that they then aren't surprised when 6 months, 1 year, 18 months, I'm saying, okay, we've reached that fork in the road that you and I had discussed. Just as Andrew Marsala said, the liver is the likely driver of mortality, and so if you're going to do surgery in pancreatic neuroendocrine, it is actually less important to understand what we're going to do with the primary, and way more important to do what it is we're going to do in the liver. So we have to meet a 70% surgical site of reduction in the liver. Patient selection is important because morbidity of the resection and the metastatic disease with the primary can be one of the more complicated cases, longer recovery, and so therefore comorbidities may weigh heavily into your ability to recover. And the strongest data is in lower grade 1 to 2 tumors where greater than 70% can be removed. And although we have definitely done cases because pancreatic neuroendocrine tumors can be mixed grade, meaning that you could get a biopsy in the liver telling you one thing, and then you go to surgery with all good intentions, and then you realize that the liver had some that were grade 3 well diff, one was grade 1 to 2 well diff, the pancreas is grade 1, and the liver's grade 3, but that it's not that we don't do surgery with grade 3 well diffs. It's just that going back to that slide that I had on my intro that talked about the surgery, if you were to take all of the 1,000 surgical cytoreductions that they had done up to around 2016 in New Orleans, only 17 of those people had a G3 well diff. Now, I think that we understand it a little bit better. Remember, I said that G3 well diffs, some will be more like low grade and some will be more like high grade. Now we have somatostatin receptor PETs giving us additional information about the tumors. And so I think between 2016 and now, I would say the proportion has gone up, but it's not like we're doing it all the time. So I think the grade of the tumor matters. So debates and controversies. Is there evidence to support watchful waiting? Unequivocal yes. Yes, yes, yes. So in grade 1 tumors less than 2 centimeters, if someone is rushing you to surgery, it's because you must look like $1 million sitting in that chair, and they are like, I need to get my kid through college. So the guidelines are out there, and these are guidelines, and that was just a joke. We aren't doing anything about college. So because we deal with guidelines and not standards, what you would never be allowed to do in breast is that we're allowed to do in pancreas. That's when I tell you that it really does matter. And so if someone is saying, hey, wait a second, I went to a conference and they said there's certain things that you can watchful wait. So chronological age, comorbidities matter because the pancreas doesn't like to be operated on. And if there is a way more likelihood that nothing's going to happen, so less than 1 centimeter, the guidelines are saying unequivocally watchful waiting. Okay, if you walk into the door of MD Anderson and you have a grade 1, less than 1 centimeter pancreatic neuroendocrine tumor, they won't even discuss any menu. And I'm like, well, you could at least talk to them about somatostatin receptor analog, therapy. It's not like that doesn't exist, but even off analog therapy, off of anything, those tumors, you could have that do nothing. You're just your natural defenses. It could be that it was just a little kid that just went a little haywire. And so less than 1 centimeter, we should not be operating on those days. Now, I think a lot of us with a grade 1 up to 2 centimeters, especially in the head or the neck, also, I'd say, hey, wait a second, let's not rush. Let's see what it looks like in 6 months' time, or let's consider some of the suppression medicine that we have, because that may be all that you would need for your entire life with that. And then greater than 3 centimeters, I think unequivocally there's something that has made it grow to 3 centimeters, and so then we have to have a reason why we're not operating. So I think that, is there evidence to support watchful waiting? Yes. And now, if I were having that same conversation about the small bowel, even if it's small and even if it's boring, the even slow growth in the small bowel makes the operation harder and makes your complication rate higher. So whether or not you're going to obstruct, bleed, or perforate in my office versus doing that a year or 2 years from now, well, we don't do that for an extraordinarily low-risk operation, no. Even in the setting of metastatic disease, we're more likely to take out an intestinal primary. In pancreas, for a variety of reasons, we just don't. So, is surgery for metastatic disease associated with an improved survival? So, the data is mixed. I think that our paper that just came out would say that the answer to that is yes. So, there is a survival advantage. You have to meet those parameters, greater than 70% surgical cytoreduction, and you have to meet those parameters in the metastatic disease. So really, what our data is saying is that the pancreas doesn't like to be operated on. The complication rates are usually going to be related to the pancreas, not the liver. So you're putting your money down on the liver. But that the reason why the data is mixed is because the pancreas part messes it up. So that you will have people that will have a very significant complication associated with the pancreas part. And if they have other comorbid conditions and you've just done this big operation with the liver component too, that may actually have a shorter life than had you just dealt with the liver and left the pancreas. So it's not about liver. If we can manage the liver, meet the 70%, even if we leave the pancreas in place, that's the controversy, is that what happens now is that if it's in the body of the tail, we take it out because it's easy, and we don't do that in the head. And so we end up then having this whole mixed bag of how we're managing it, which is not a great way to manage cancer, but that it just is the way it is because the pancreatic neuroendocrines come with these unique issues. So the stronger data is resecting the metastatic disease versus the primary. And then minimally invasive surgery in PNET, it's sort of standard for the distal. And so if someone's not offering you that, then, oh, sorry, Bob. I'm almost done. And then it's not the standard of care in higher grade. I'm going to start talking really fast. And then liver surgery, you already talked. Liver surgery is honestly, we don't do major resections like we do with primary liver cancers or metastatic colorectal. In general, we do what's called parenchymal sparing resections, meaning that you are literally chiseling these out, almost like chiseling them out like an egg out of an eggshell. And so, once again, if people are not familiar with that technique, then I think it can be very hard, but that the point in neuroendocrine is that in people that live a long time, you can't burn a bridge by taking out too much functional liver trying to get these tumors out. And so if you do anatomic resections, which are so much easier than neuroendocrine metastatectomies in the liver, then you are going to then burn the bridge, because then you're going to lose a bunch of functional liver. And yes, that liver can regenerate, but a regenerated liver is not going to tolerate chemo as well. A generated liver is not going to tolerate other medical conditions. A regenerated liver is not going to tolerate the same medications. And so I think that we do not really use anatomic resections unless it's a very large metastasis. Instead, we use sort of something similar to an enucleation. And this is kind of what it looks like. So this is what they look like in the liver, and you really are just taking out this little part here. You're just like scooping them out, almost like melon scooping. This kind of looks more like a segmental resection. We really do more of a scooping, kind of a melon scooping. Yeah. Lastly, human respiratory system, very similar. You have your trachea. It separates into two lobes. It's like a tree, just like the liver, and you can literally take out a little bud of the tree, or you can take out a whole branch of the tree, or obviously you can take out a whole half of a tree, but obviously unless you're going to transplant it, you can't take out both trees. So in bronchopulmonaries can also be relatively challenging, but for the most part, they are rarely metastasize. When they metastasize, they can be very challenging, but the surgery component of it is relatively straightforward. You're just looking at it and saying, can I get it out of that tree? They are often done minimally invasive too. So this is just called a wedge resection. They're just taking it out and ultimately taking out a little piece and saving all of the rest of that lobe. That is actually very relevant if someone has what's called a typical bronchopulmonary. So they come as typical or atypical. Typical is often overlapped with other pulmonary hypersensitivities because you have neuroendocrine cells in your lungs. They're responsible for getting the stuff out. So you do something, it's really irritating, you get a bunch of fluid in there, and then the neuroendocrine cells get stimulated, and the thing that's coughing out is it's trying to cough it out of your body. So people with bronchopulmonary, especially typical bronchopulmonary, can present with things that are like exacerbations of asthma. And so a wedge resection is really what we do when you have no other evidence of disease, and we're just trying to put it in the typical category, because a typical bronchopulmonary it can be problematic from a symptom standpoint, but if you remove it, the symptoms can often get better. And then even when you have multifocality, meaning like tiny little small weeds, we don't go big or go home with typical bronchopulmonaries, and people will often be managed even without somatostatin receptor analogs, but then there are going to be people that require those. And then if we had someone here that was a bronchopulmonary expert, they could talk to you about some of the unusual things that happen to bronchopulmonary, like dip neck or things like that. And then I would say that the specialist for that problem, if any of you have bronchopulmonary and dip neck, would be Rob Ramirez at Vanderbilt. And then, or you can take out a whole lobe, or you can take out a whole half a lung. It is really unusual to do a pneumonectomy for neuroendocrine, but oftentimes it's when you are doing it with curative intent, meaning that's the only evidence of disease, and you're doing it in a young person with curative intent. Okay, so the treatment options are not mutually exclusive. That was the same from my intro. And so the strongest evidence, this is the summary, strongest evidence is in G1, G2 midgut cases. You need to meet a 70%. Less robust evidence, but clear evidence in metastatic PNET. It's mostly going to be large series from neuroendocrine subspecialty centers, and that's predominantly because the pancreas is complicated. And then weaker evidence in metastatic lung or broncho, but the fact is we use the same parameters, and I can tell you I inherited a program that was 30 years in the making, and I have people with metastatic bronchopulmonaries that had cytoreductions done 32 years ago. So I never want to sell people short. Usually we are doing it in young people that have a strong heart, otherwise strong lungs, strong kidneys, no other significant medical problems. And then very weak evidence in high-grade tumors. So this is just if someone was to make a summary slide, if you're trying to figure out where you fit in on the thing. And then if you don't want to take a picture now, you can probably get a copy of these slides. So my advice, it's all the same as it was. Oh, wait, no, not all the same. Is that I said you have to be really judicious. You have to be really judicious in where you're doing treatment, especially in low-grade tumors. You got to play the long game in neuroendocrine, and you have to play the long game, especially when it comes to surgery, because you do not want surgery to influence your ability to take advantage of any other treatment option, because the menu is just getting longer and longer. Okay, and this is another one, email.